Festive greetings and compliments of the season to you. Hope you and your family are well and enjoying this special time of the year and keeping safe. Dr. Ryan here. I'm a board-certified specialist physician. Thank you so much for joining me even as we cover a head-to-toe clinical approach to cerebellar pathology. If you haven't yet subscribed to my channel, I strongly encourage you to do just that. Alrighty, so as customarily the case, we can approach our patient. First up, introduce yourself and obtain consent for the examination, right? Then just step back and look at the gestalt of the case, the general appearance of the patient. Does the patient appear unkempt, which may be a clue that maybe they are using alcohol, that they're addicted to alcohol, right? Is there any scoliosis which lends itself to Friedreich's ataxia? We'll be talking about Friedreich's ataxia, which encompasses cerebellar pathology in its diagnosis. Right? Is the patient paraplegic? I'm thinking about a demyelinating syndrome. There's a whole lot of those, like multiple sclerosis or acute disseminated encephalomyelitis, which is ADEM. Right? Then engage in conversation and listen to the patient's general speech. Are there any special phrases which may imply dysarthria? Is there staccato speech, so-called detached speech? And ask the patient to walk, especially tandem walking or heel-toe walking, which is almost impossible for a patient with cerebellar pathology, right? And very clumsy in terms of their gait, and they also have a wide base gait, all right? Then you ask the patient to stand with the eyes open and you check for truncal ataxia, so the Romberg sign, right? Tandem heel-toe gait we mentioned, and note the side of deviation, because the side to which they deviate is usually the side on which they have the cerebellar pathology. It's ipsilateral, right? Note the head and the eyes. Is there any titubation? Remember, a differential for titubation of the head could be aortic regurgitation with demused sign, right? Is there any nystagmus? Usually it's vertical nystagmus. Check the corneal reflex, which may imply cranial of 8 neuroma. Optic atrophy, which may give a clue in terms of demyelination, Friedreich's ataxia, or a nutritional cause behind the presentation. Look into the mouth and check for any gingival hypertrophy, because this is a clue to phenylketonuria toxicity, which we will see is actually one of the iatrogenic causes of cerebellar pathology. Is there a so-called bull neck, which implies it could be an underlying Arnold-Chiari malformation. Look at the upper limbs for hypotonia with the arms extended. You note if any drift, any dysmetria, which is past pointing, right? Any tremor, which could be just a flap or could be a fine tremor. Note for rebound, intention tremor, and dysstereokinesia. Right, in the lower limbs, we check cerebellar pathology with foot tapping, the toe finger touching, which is the lower limb equivalent of testing dysmetria, the heel shin test, and any pes cavus. Etiological clues: if there's spasticity, everybody, that could imply that there's a tumor or a demyelinating pathology present. If there's liver disease stigmata present, you can probably bet your bottom dollar this is an alcoholic. If there's neuropathy, you're thinking Friedreich's ataxia or alcohol, because alcohol can also cause a peripheral neuropathy. Clubbing or nicotine staining, you're thinking about carcinoma of the lung. Dissociated hemisensory loss, you're thinking about the posterior inferior cerebellar artery syndrome, the PICA syndrome. Not pica when it comes to iron deficiency. This is pica in terms of the artery. And chorea, there could be underlying Wilson's disease, right? So this is the same approach in a different form. So we said we're going to check the gait. Note also your pendular knee jerks, right? Kind of like circular motion, right? Dysstereokinesis and rebound when you're testing the upper limbs. Truncal ataxia, asking the patient to sit up in bed or to stand. Nystagmus, right? Speech, note staccato speech, upper limbs, the arm drift, the tremor, the hypotonia, finger nose test in terms of dysmetria with the check the legs of the patient lying down, note any hypotonia, heel shin testing. All right. So this is essentially to show us the anatomical and functional correlates, right? So we know that the cerebellum is conceptually divided into different sections, right? We have the central portion, which is the vermis, and then we have the hemispheres, right? The right and left hemispheres. We also have the vestibular cerebellum, right? So when patients present with predominantly truncal ataxia, the pathology is in the vermis, and alcohol usually affects the vermis, right? But if there's peripheral stigmata of cerebellar affectation like dysterococchynesia and rebound and Heelshan testing being positive and dysmetria, etc., then it's probably not the vermis, it's probably one of the hemispheres, right? So in the spinocerebellum, which forms part of the vermis, we have the vestigial component and the interposed. And these then give rise to the medial descending systems and the lateral descending systems, respectively. That's responsible for motor execution, for execution of planned motor movements, right? The dentate nucleus, which is areas 4 and 6, are responsible for motor planning. Vestibular nuclei for balance and eye movements, all right? There's a nice acronym here for the features, the clinical features of cerebellar affectation. Danish, right? Coming from Denmark, right? Danish. D for dysterococchynesia, right? Let's get my pen in there. D for dysterococchynesia, A for ataxia, N is for nystagmus, not nystagmus, right? I is an intention tremor about 3 Hz in terms of the velocity of the movement or the frequency of the movement. S is for speech, which is scanning or staccato speech. H for hypotonia, right? And then in terms of the etiologies, there's another beautiful acronym called pastries. So they go together like a Danish pastry. Yummy. P for paraneoplastic, A for alcohol, A for sclerosis in terms of multiple sclerosis, T for underlying tumor, R for rare being Friedreich's ataxia or multisystem atrophy or ataxia-telangiectasia, I for iatrogenic in the way of phenytoin toxicity, E for endocrine in the way of hypothyroidism, S in the way of stroke being vertebral bacillus stroke. So Danish in terms of the features, pastries in terms of the etiologies. Very nice. Okay, guys, this is in a nutshell encompassing cause of cerebellar disease. So we said if it's a rostral vermis lesion, that's central affectation, usually truncal ataxia, usually due to alcohol. If it's unilateral, it could be space-occupying lesion like a tumor, abscess, granuloma. Ischemia in the way of vertebral bacillus disease, we spoke about this, multiple sclerosis or trauma. Bilateral affectation, there's a whole lot to talk about. So drugs like phenytoin, alcohol, on account of both acute and chronic involvement, possibly due to thiamine deficiency, Friedreich's ataxia, spinocerebellar ataxias, hypothyroidism, paraneoplastic affectation, multiple sclerosis, trauma, right, etc. Midline issues, a midline tumor or a paraneoplastic syndrome. Now, just to touch a little bit on Friedreich's ataxia, what is this? It's an autosomal recessive condition, right, which presents predominantly with cerebellar signs, which is bilateral, including nystagmus. You also get pes cavus, cocking of the toes, kyphoscoliosis, right? Other causes of pes cavus are HMSN, hereditary motor sensory neuropathy, or Charcot-Marie-Tooth disease, spinocerebellar degeneration, and childhood neuropathies. You may also have upper motor neuron signs in the limbs, although reflexes are absent, peripheral neuropathy, posterior column loss, cardiomyopathy, with ECG anomalies in about 50% of cases. What is common is diabetes mellitus together with this. Right? That's why the endocrinologist is very interested in Friedreich's ataxia, optic atrophy, and normal mentation. And then, of course, we talk about causes of spastic and ataxic paraparesis, which is upper motor neuron signs and cerebellar signs combined. In adolescents, we're thinking about spinocerebellar ataxia. In young adults, we're thinking about MS, spinocerebellar ataxia, syphilitic meningomyelitis, which is usually tertiary, and anal Chiari malformation or other lesions at this craniospinal junction. In later life, we're thinking about MS again, syringomyelia, infarction, especially in the upper pons or internal capsule on one side, which gives you the infamous ataxic hemiparesis, or a lesion at the craniospinal junction, like meningioma. Okay, my friends, the book of 2 Corinthians chapter 4, verse 18, beautiful verse. It says, "So we fix our eyes, not on what is seen, but on what is unseen. For what is seen is temporary, but what is unseen is eternal." We should always live with eternity in mind. My friends, the life that we live on this earth is simply a vapor. It's like a mist. It is here today and gone tomorrow. Our eternity is what counts. And the book of Acts tells us there is no other name given under heaven by which men are saved except in the name of Jesus Christ alone. The book of John 14:6, Jesus says, "Behold, I am the way, the truth, and the life. None comes to the Father but by me." John 11:25 declares, "Behold, I am the resurrection and the life. He that believes in me, even though he is dead, yet shall he live, and he who lives and believes in me shall never die." Revelation 3:20, Jesus says, "Behold, I am at the door of your heart, and I am knocking. Blessed is the man who answers, so I can come in and fellowship with him and him with me." I pray that we will always live with eternity in mind and not just earthly, temporal things. God bless you. Have a lovely day. I'll see you soon with another helpful video on my channel in this series. God bless.